Join Cranmer, MD, City of Hope, as he breaks down the most important soft tissue sarcoma updates. The combination of doxorubicin plus trabectedin has shown an overall survival benefit in leiomyosarcoma. In dedifferentiated liposarcoma, Abemaciclib demonstrated a clear progression-free survival advantage over placebo. Biomarker-driven and histology-specific strategies are becoming more important than ever. Knowing the exact sarcoma subtype is now critical for treatment selection. New data are reshaping treatment decisions in leiomyosarcoma and dedifferentiated liposarcoma. In 3, 2, 1. How has the neoadjuvant pembrolizumab plus radiation data changed your practice for high-risk extremity undifferentiated pleomorphic sarcoma?
So I think the data from that particular clinical trial combining pembrolizumab with neoadjuvant radiation therapy, which was so this clinical trial, so patients got combination of pembrolizumab and neoadjuvant radiation therapy, had surgery, and then had, I believe, 14 additional cycles of pembrolizumab given adjuvantly. So it's not just neoadjuvant therapy, it's neoadjuvant and adjuvant therapy in patients who are high risk of disease recurrence. And this was a randomized trial compared to neoadjuvant radiation therapy alone, which would have been a reasonable standard of care in these patients. The fact that there was a significant improvement in progression-free survival, and it seemed, based on the analysis of the recurrences that were seen, it seemed to be primarily impacting the risk of distant disease developing. I think given the tolerance of the regimen, given the fact that it's a regimen that's very familiar to most oncologists in practice because it's a widely used drug, I think it's a very important addition to our treatment, and I am frequently offering this to patients, including patients who I would not have considered, for example, perioperative chemotherapy in, because they couldn't tolerate it. But many patients can tolerate this therapy, and with a significant, and I believe clinically significant improvement in progression-free survival, I think it justifies use of the combination.
What is your current first-line approach for metastatic leiomyosarcoma based on the doxorubicin plus trabectedin results?
So I think the clinical trial presented in the New England Journal of doxorubicin and trabectedin in patients with leiomyosarcoma is a game changer in the management of leiomyosarcomas. It showed a marked survival benefit, including extended improvement in overall survival going out to 5 years, although there were only a limited number of patients being followed at that point. Now, like most combination therapy trials, this was at the cost of increased toxicity in the combination component of the trial. Now, remember, this is a clinical trial which had basically 6 cycles, call that 4 or 4.5 months of combination therapy with doxorubicin and trabectedin, and then the patients would transition to trabectedin monotherapy as a maintenance treatment for up to, I believe, a total of 17 cycles of treatment. So you can think of it as a year or year and a half of treatment, somewhere between those two, and then the therapy would be discontinued. The fact that there was separation of the survival curves, and interestingly, that occurred after completion of the combination therapy. It occurred during the maintenance therapy component of treatment. And this was a persistent effect, and although patients who received doxorubicin monotherapy could potentially have crossed over to receive trabectedin if their disease progressed, that did not rescue the patients in the doxorubicin arm in terms of overall survival. So there was effectively crossover allowed, and despite crossover, the combination arm with the prolonged maintenance treatment showed persistent improvement in overall survival. Now, one question with this is, what do you do in patients who are going to have difficulty tolerating the combination? As I said, the combination therapy had clearly worsened adverse events. It was a very, very high rate of adverse events, as you'd expect